Well, hello, I'm Dr. Sherman Silber, Infertility Center, St. Louis, St. Luke's Hospital here in St. Louis, and I'm going to be talking to you on Facebook Live now, answering questions, and I won't have time probably to answer all the many questions that come in, but you can also reach us on the website, infertile.com. That's INFERTILE.com. Infertile.com is our website. And I'm here to answer questions. I'd like to make a few controversial points to start with, though, because people are always bringing this up. Patients come into us every day and they say, you are going to genetically test the embryos, aren't you, right? And they don't have any understanding of what's really involved. Now, we did all the earliest work, going back in the 90s even. We've written papers on it, New England Journal of Medicine, controlled randomized study, on biopsying an embryo and testing it genetically. I've got to explain to you, because I do know what I'm talking about. If you have a single gene mutation, you're a carrier for a disease, we can very, very accurately diagnose that in the embryo, and preferentially transfer embryos that don't have that disease, usually a lethal disease. We can transfer the healthy embryos, sure. But this idea of just screening everything, it can't be done. You can count chromosomes, and that's all that this is, PGS, or genetic counting chromosomes on every embryo. But that lowers the pregnancy rate, because you're going to misdiagnose many embryos as abnormal and throw them away that would have been a baby. And the reason is, or one of the many reasons, in the first place, the technology isn't perfect. 5% of the time, if you diagnose it as a girl, it's really going to be a boy. So the technology is not perfect. Right there's errors. But also, just the biology. The trophectoderm, or that part of the embryo we biopsy, which will become the placenta, is filled with abnormal cells. The placenta works perfectly well with 100% abnormal cells. So there's always going to be abnormal cells in that placenta. And so when you biopsy it, you're going to have normal and abnormal cells, and it becomes really problematic to try to interpret what the embryo is from what you're biopsying. And you're certainly not going to biopsy the embryo itself, because you would really damage it or cause defects. Everybody knows that. So there are certain indications for doing genetic screening, but you have to talk to each patient individually about it and see who might or might not benefit from it. That's not the same as genetic testing. PGD, really accurate. But if you're not a carrier of a particular disease, then the genetic testing is very questionable. We see so many patients, older patients particularly, that have had this testing and been told, well, they don't have any normal embryos. And we do IVF with mini IVF, and they get pregnant and have babies, and we don't have abnormal babies. So you got to be really careful about that. The other little contentious point I want to make before I answer questions is about, do we have to do IVF? Is there some other treatment? Well, of course. It really depends on the age of the woman, how long they've been trying to get pregnant unsuccessfully, what the sperm count is, and their whole emotional demeanor, how anxious they are. All these things are individual. So we talk to every patient about what their situation is and decide what's best for them. Sometimes just sexual counseling is all that's necessary. Just advice. Sometimes watchful waiting is all that's necessary. So, it's not automatically going to be IVF, but particularly if it's an older woman where her eggs are beginning to go downhill, she has to be much more aggressive than a younger woman. So those are a couple of pet points I wanted to make before we started answering questions.
Wonderful. Thank you for doing that. And that's one of the things I've noticed about the questions that we've received since the last Facebook Live, is that a lot of times you get sort of stuck answering the same questions over and over. And I think there's value in that people may just need to hear it at that right time. But the thing I've noticed here is that we're getting some more specific questions. So I think it's a kind of a good lead-in that we can cover some of the big issues right off the bat and then look at some of these more specific questions. So the first question we have today was sort of a continuation of a question that you answered last Facebook Live. about transferring more than 2 embryos. The reader said, I'm 39, starting IVF once my cycle starts. She's in Switzerland, and the maximum that they will transfer there is 2. So she's curious about what age you, Dr. Silber, are most comfortable when you're transferring more than 2 embryos.
Well, I'm glad to speak to you all the way in Switzerland. We have patients from all over the world, including Switzerland. The general view in America also is, if the woman is under 40, we wouldn't want to transfer more than 2 embryos. Some people prefer only 1 embryo. At any age in America, we're transferring 2 embryos on more patients than in Europe. And that's because American women have to pay out of their pocket for IVF, and they want the highest pregnancy rate per transfer because many people are saving up for years for IVF. So the risk of transferring 2 embryos is you might have twins. Frankly, this is not going to be PC to say, but it's not a terrible risk. And with modern prenatal care and obstetric care, it's a more difficult pregnancy. This is not a terrible risk, having twins. Many women prefer it. But if one of those embryos splits and divides into 2, then you might have triplets. And that's a big risk. And that is about a 1 in 300 chance of that happening. So if we transfer 2 embryos, there is a 1 in 300 risk of triplets. And so that's a risk. So women will have to decide whether they want to transfer 2 or 1 based on that. Most American women prefer to transfer 2. But our views in America are the same as Switzerland, that we would never transfer more than 2 unless the woman is over 40 years of age.
Thank you. We just had a question come in from Kay. She asks that she explains that she has stage 4 severe endometriosis, and she's curious if she can still get pregnant.
Well, stage 4 endometriosis is more common than you might think. It's very common. You can only make the diagnosis accurately with laparoscopy. If you try to make that diagnosis with just ultrasound or MRI, you're not really going to be accurate about it. You have to actually see it. Frankly, I found the success rate, pregnancy rate, at least with IVF, is no different in women with severe endometriosis than in women that don't have endometriosis. So, what is endometriosis really doing? It's very confusing. Some people say it has some effect, which is very, very vague on the overall pelvic environment, but that's really not a very scientific statement. It doesn't make any sense. When you have endometriosis, that is endometrial tissue, like tissue of the lining of your uterus, that is located outside your uterus, maybe in your abdomen or on your ovary or near your fallopian tube. So when you menstruate and you bleed out through your cervix, also the endometrial tissue is breaking down and, so to speak, menstruating inside your abdomen. So that causes inflammation and adhesions, and so it can cause problems with egg pickup and tubal function. But the pregnancy rate, at least with IVF, is no different in women with endometriosis than without endometriosis.
Thank you. Next, Mindy is asking, do you use IUI or only IVF?
So that's a very important question I alluded to early on in this. Do I use IUI or only IVF? Well, let me explain. We do whatever is appropriate for the patient, and we go by the patient's own needs and emotions. But IUI is the first line of treatment in most centers, and frankly, it's a very ancient approach. Now, we go back many, many, many years to the early days of IUI, and the only reason IUI was ever invented is doctors who were infertility doctors in the 70s and early 80s did not know how to do IVF. They didn't have cell culture. They had no idea how to do it, and they felt left out. So they came up with this thing. It came from USC, that all you have to do is use a urinalysis centrifuge tube, wash the sperm, and then put the sperm in the uterus, and it's as good as IVF. It was really stupid, but it caught on in a huge way because it seemed like it was a less expensive way to do this high-tech thing that nobody knew how to do in the early 80s, which was IVF. I was there at all the meetings when it was talked about. Now, we compared IUI with intercourse. If you don't want to do IVF, IUI definitely will not improve the pregnancy rate over just intercourse. And if you're going to have good success with IUI, you have to do it with hyperstimulation, with stimulation with hormones. So if you're going to stimulate with hormones, again, we found many years ago that the pregnancy rate with intercourse was as good as it was with IUI. In fact, it's better. Because with IUI, the washed sperm goes into the uterus and is gone right away, and it goes out the fallopian tubes, and you never get the timing exactly right. Not like IVF, where you get the timing exactly right. So the egg is ovulated, and it might be already too late by the time the sperm gets in, or the sperm might be all gone by then. With intercourse, the cervical mucus gradually allows sperm to go up in almost platoons up into the fallopian tube to fertilize the egg over a 2 to 3 day period. So you don't have to worry so much about timing if it's intercourse. So that said, if IUI is what seems to be the best thing for the couple, that's fine to do. But and it's okay, we'll do it. Our program offers that. But it shouldn't be automatically the first approach, because you could waste a lot of money on it if it's not appropriate for you.
Thank you. All right. The next question we have is from Sari. She's 40 years old, has to go through her first IVF. Do you have any recommendation, and this, which clinic in Europe is experienced in mini IVF? Many clinics here do not know as much about mini IVF and are recommending conventional IVF for her.
Well, yes. Most clinics are afraid of mini IVF because it's easier on the patient but more difficult for the doctor. You really have to have a perfect lab, but you also really have to know your endocrinology really, really well, or you wind up with premature ovulation and failed cycle. But if you do it right and you know how to do it, it's easy on the patient, and we get the best quality eggs. So I certainly would always recommend mini IVF for 40-year-old. It doesn't matter that much when you're younger and your eggs are naturally better. But for 40-year-old, you want to get the best and only the good quality eggs. As far as specific clinics are concerned, I can't really recommend specific clinics. I mean, it'd be like advertising, and you never know for sure whether someone's going to have a good experience or not. What I always recommend when people ask me to recommend a clinic is you go there, you talk to them, and you quiz, and you see how you feel about their answers, and you sort of have to make a gestalt judgment about whether it's the right clinic for you. I can't just tell you what clinic to go to.
Thank you. Kimberly is asking if it's possible to come in and do the IVF, freeze the embryos, and then do PGS later.
Yeah, so the question is, can we do IVF, freeze the embryos, and do the PGS later? When she says PGS, what she means is the genetic screening. That doesn't mean genetic testing for a mutation. It means counting the chromosomes to see if it's, what we call aneuploid or euploid chromosome. And we can freeze the embryos with impunity with our vitrification that we originally brought to the U.S. In 2003. And we won't hurt the embryos when we freeze them. We can store up embryos and wait till you've accumulated a lot of them and then do the PGS on all of them at one time. So if PGS is indicated for you, we can do it on stored up frozen embryos easily, no problem.
Thank you. Olivia is asking what your suggestion might be for getting pregnant if she has irregular periods, or recommendations about how to regulate those periods.
Okay, so the question Olivia has is, what do we do for irregular periods? Well, it's a broad statement. What if your periods are sometimes 23 days apart and sometimes 60 days apart? Or what if you only have a period every 3 months or even every 6 months? So severely irregular periods almost always means PCOS. Almost always. That means that you're not ovulating, you're not having a normal synchrony of the elevation of FSH when you menstruate, recruitment of a dominant follicle, And then there's just a beautiful synchronized process whereby as your estrogen level goes up towards mid-cycle, it causes an LH surge and you ovulate, and this occurs in 14 days. And then 14 days later, if you aren't pregnant, your corpus luteum gives way and you menstruate again, and you have 28-day cycles, or 27-day cycles, or 29-day cycles. But when you have severely irregular cycles, it almost always means you're not ovulating. When you're not ovulating, it almost always means PCOS. Now, there's a lot of confusion amongst doctors about PCOS, but I think it's very, very, very clear what it is. You're born with a lot of eggs. Your ultrasound will show a very high antral follicle count. Your AMH will be extremely high. You're born with a high number of eggs, and you're going to have a very late menopause, so that sounds good. But the problem is that suppresses your FSH level at the beginning of your menstruation, and you don't really recruit a dominant follicle. So you may even ovulate late, maybe on day 20 or day 25 or day 30, and that's not a good egg. But you don't ovulate in a normal, regular way because you're not recruiting a dominant follicle on day 1 of your menstruation. And that's usually because, it sounds weird to say that, you were born with too many eggs. So what do we do about it? Well, we put you on birth control pills and we regulate your cycles, 21 days on, 7 days off. And then after we regulate your cycles, we can stimulate you either to ovulate or for IVF. The advantage of IVF is you don't ever worry about a multiple pregnancy because you can transfer 1 embryo or 2 embryos, but you don't worry that you've had too many ovulations and wind up with quintuplets or sextuplets or something like that. So that's the advantage of IVF. But go on birth control pills first. You drop the FSH and the LH. You get everything down to baseline, and then you can stimulate properly.
I have a couple of questions that are related about male fertility, so I'll try to keep those together. The first one is from Zeba in India. And basically, I can give you some more of the stats, but his question is there any chance of sperm retrieval in a case of maturation arrest?
Okay, so this is the question. I'm sure he's azospermic, that is, no sperm in the ejaculate, and the diagnosis has been made of maturation arrest. Well, there are really ultimately 2 diagnoses for not having sperm in the ejaculate. One is maturation arrest. That means you're making the early precursors of sperm, and then you're not maturing into full sperm. The other is Sertoli cell only, and that means that you really don't have any sperm precursors. Now, both of these are partial defects 60% of the time, and it's no different. So our success rate with maturation arrest, finding enough sperm for ICSI, is no different than for Sertoli cell only, or for cryptorchidism, or post-chemotherapy. It doesn't matter what the cause of the azoospermia is, including maturation arrest. We have a 60% chance of finding maybe a tiny number of sperm, tiny number. But that's all you need for ICSI to inject into the wife's eggs and have a normal pregnancy rate.
Thank you. The next question is from BA in Kenya. We're all over the world.
Hey, that's
today.
great. Kenya, India,
That's
Switzerland,
right.
We're reaching out.
Is it possible to retrieve sperm from a man, they say, with invisible testes? Could that be undescended?
Well, I think if he talks about invisible testes, he means undescended. Well, there's a problem with undescended testes. As long as the testes are undescended, you're not going to be making sperm. So what has to happen is the testes have to be surgically brought down into the scrotum. Ideally, this should have been done when you were just a baby. So when you're an adult, the improvement is more problematic. Some people say there will be no improvement. We certainly had improvement in young adults with no sperm caused by cryptorchidism or invisible testes or hidden testes, however you want to call it. And but you have to first operate to bring them down, and then you have to wait a year to have the maximum chance of sperm production returning. And that's because the testes cannot make sperm in the body's temperature of 96 to 98 degrees. It has to be in the scrotum with a lower temperature in order to make sperm.
And similarly, Chetan suffers from Sertoli cell-only syndrome. Therefore, is it possible to retrieve viable sperm for him?
Question is it possible to retrieve viable sperm from a man with Sertoli cell only? Absolutely. Same chance, 60% chance. And we may wonder what's going on. Well, when you're making a tiny amount of mature sperm, whatever the cause of the problem, tiny amount of mature sperm, you have to exceed a certain threshold, very low threshold, for anything to spill over into the ejaculate. So when there's nothing in the ejaculate, there's a 60% chance that there's a tiny amount of sperm in the testes, but not a sufficient quantitative amount to get into the ejaculate.
All right, so for now, that's it on the male fertility, but we do have a viewer that watched one of your older videos about an ovarian transplant from sister to sister, but they're curious, is it possible to do with some sort of matching ovarian donor?
So the question is, we're pretty famous for doing those ovary transplants between identical twin sisters, and also for freezing the ovary tissue, say of cancer patients before their treatment makes them sterile, and then transplanting the tissue back 15, 20, 25 years later, and having normal ovarian function and spontaneous pregnancy. And there is no need for IVF with any of this. You just get pregnant naturally. No need for IVF. So the question that's just was brought up is, can we do it with sisters that aren't identical twins? Well, yes, of course we can. But we would have to use immunosuppression, very much like a kidney transplant. And we have done it. But you have to think carefully, because if the sister's wanting to donate her ovary and then the recipient go through immunosuppression, it might be easier just to donate some eggs, and then there's no need for immunosuppression, although there'd be a need for IVF. So there are certain religions where you really can't do donor eggs, but as long as the egg is ovulated inside the woman who's getting pregnant, it's okay. So that would be a good indication for doing a transplant of the ovary from a sister to a sister, even though they're not identical twins. But you'd have to use immunosuppression.
Thank you. From Raisha, a trans woman friend of mine had her... a trans woman...
Oh, okay, trans woman. Okay, I got it.
Had their gender... their
From
GRS.
male to female?
Yes.
Yep.
Can she get an ovary transplant and therefore then become a successful mother?
Well, okay, so I've had a lot of experience going back 50 years, actually, with transgender, before it was so commonly open situation. And so there's male to female, so to speak. In other words, a male that changes to a female because he's always felt he's a female but trapped in a man's body. And then there's female to male, where it's a woman who really has always felt like she's a male. We're not talking about homosexuality or lesbianism. We're talking about a true gender dysphoria where the male thinks he's a female and he's stuck with male body, or the female thinks she's a male and stuck with the female's body. So my most interesting case was long before IVF in the 1970s, where a man came in who wanted to be a female, and but he also wanted, obviously, to have babies. He wanted to have his own genetic baby. So what were we supposed to do? So, and there was no such thing as IVF in those days. So I said to him, well, okay, I'm sure can find in your social groups a female that feels she's a male and wants to change. Neither one of you change, get married, have intercourse. Emotionally, psychologically, it'll feel the same as though you changed. And they wound up having 3 babies naturally. So that was one of my great psychological achievements. That was in the early 1970s. But the question is, what can happen? Well, if a male is going to become a female, of course, he gets his testes taken out, and it would be a real good idea to freeze his sperm first. And so then he's going to become a female and marry or have a partner that's a male. So what they can do is it can be like almost the same as a lesbian couple would, and you could take his frozen sperm, and you could get an egg donor and a gestational surrogate, and they could have a baby that way, just the way homosexual woman? Or what about if you have a female that wants to be a male? Well, before she has any surgery, you could also use donor sperm and use that even for insemination, not even IVF. IUI would be fine. So it certainly can be done. There's no reason why LBGT couples cannot have babies, but you'd have to have sort of an open mind about donor sperm or donor eggs.
Yeah, that's amazing. It was a curious question, but it's one of those I can see how someone would ask that. So
more than you realize.
Right. So Taylin asks during while you're talking, she researched you. You do amazing work. I have hypothyroidism and newly married to a husband who does not have children, and they want at least one. She has 3. Her tubes are sewn, not tied, and her doctor says it's reversible. I want IVF, but what are your thoughts?
Well, of course, we did the first microsurgical tubal reversal in the United States in 1977, so it goes back a long way. So as long as they didn't destroy the fimbria or more than 2/3 of your fallopian tube, we can certainly put the fallopian tube together, and that's the easiest thing to do. Your hypothyroidism is no big deal. That's the simplest endocrine condition in medicine to treat. It's not a big deal at all. And a tubal reversal is just fine. You don't need to go. Now, many women will go through IVF, or they go to an infertility center. The infertility center says, well, we don't do microsurgery. I mean, most infertility doctors nowadays do not know how to do microsurgery. They really don't. They're not trained in it. But all they can do is aspirate eggs and do IVF. That's not us. I'm the father of microsurgery. But we can certainly just do a tubal reversal, and it should be successful.
All right. Let's see. For PCO, I know you spoke about PCOS earlier, but Mindy has a specific question. For PCOS, do you recommend daily progesterone? When she takes it, she menstruates regularly. One doctor recommended Provera every 30 days, but it's very hard on her. She would prefer the daily progesterone, but would that hurt or help her chances of getting pregnant?
I think it's a bad idea to go on daily progesterone. I think it's better to be on standard birth control pills, 21 days on, 7 days off. And in fact, if a woman is not trying to get pregnant and she has PCOS, there are health problems associated with untreated PCOS. A higher incidence of endometrial cancer later in life, and a higher testosterone level, giving her a higher risk of heart disease later in life. And so I'm not in favor of leaving PCOS alone, even if you're not trying to get pregnant. But I think the easiest, simplest treatment is birth control pills, 21 days on, 7 days off. Now, if your doctor gives you a low estrogen pill, that's a big mistake, because then it's very progesterone dominant, and the synthetic progesterones can cause really terrible PMS and be really uncomfortable and make you really weird. So many women have a hard time with these low estrogen pills. Estrogen is the kind hormone, and synthetic progesterone is the nasty one. So I would recommend just 21 days on, 7 days off of 35 microgram pill with a better progestin than norethindrone, like the usual one is Desogen or Reclipsin or Acela or Marvelon. There are a lot of different names for them. But that combination I think you'll find very pleasant, and you'll really be relieved of this irregular periods. Your testosterone level will come to normal, and you'll protect your health. And so I say if you're trying to get pregnant with PCOS, okay, do ovulatory stimulation or IVF. And if you're not trying to get pregnant, at least be on birth control pills.
One last question I want to get in here, just because it's come up. I know we've talked about endometriosis a little bit earlier in the broadcast, but Nicole is asking, or she's stating that she has severe endometriosis and has had 3 failed IVF cycles. She's got 1 embryo left. Does endometriosis reject the embryo? They're really having a hard time on figuring out what to do.
Well, I know the question is endometriosis causing her to have 3 previous failures of implantation. Well, I don't know from her question what her age is, and the critical thing is the age of the eggs and what the embryos really look like. I don't have that information. But I can tell you that the endometriosis will not cause the embryo to be rejected. Some people may tell you that, but they're totally wrong. It's erroneous. Endometriosis will not impede the implantation.
Thank you. That's all the questions we have. We had a very active community tonight, so
well, that's
I
great.
really
We
appreciate
talked all around the world
to
everyone. So this is Dr. Silber, Sherman Silber from St. Louis, talking, I guess, to Kenya, Switzerland, I don't even India, and Europe, all over the world, and we're glad to answer your questions. And you can either come up with these questions next time we do Facebook Live in a month, or you can go to infertile.com. Thank you very much.